This is Dr. Howard Strassler presenting the e-lecture Pulpal Protection, Bases, Liners, Sealers, Caries Control, Module D, Pulp Capping and Caries Control. What is pulp capping? Well, the definition of pulp capping from the American Association of Endodontists, from their glossary of endodontic terms, is a pulp cap is a treatment of an exposed vital pulp by sealing the pulpal wound, the exposure, with a dental material such as calcium hydroxide or mineral trioxide aggregate to facilitate the formation of reparative dentin and, most critically, the maintenance of a vital pulp. And so we can break pulp caps into two distinct groups, indirect pulp capping and direct pulp capping. An indirect pulp cap refers to the fact that when we open up a tooth, we'll see some caries. That radiographically we can see that the caries is close. We're going to take some clinical data to make a decision whether to do with the indirect pulp cap, but during the procedure we're going to leave some leathery dentin over the pulp tissue. We're not going to expose the pulp. We'll then cover that with Di-Cal and then cover it with Vitribond and place our restorative material. To make the decision to do an indirect pulp cap, we need to have certain clinical considerations. First off, the tooth must be vital. No history of spontaneous pain. The patient would basically tell us that the tooth is asymptomatic. We should have no percussion sensitivity of the tooth. There should be no pain elicited from a cold test or an EPT, and that pain should not linger. Restoration must seal the tooth from bacteria, so whether we place an amalgam or a composite, no bacteria should be able to get in. When we look at a radiograph, we'll see no periapical pathology present. And most importantly, the tooth will not have a definitive casting as a definitive restoration, whether it be a fixed or fixed casting or removable partial denture casting. If you're going to do that procedure, you're going to remove all the caries. If the pulp has a carious exposure, you're going to proceed to endodontic treatment. So what's the technique? Well, here we have a class 5 carious lesion, a deep preparation. The tooth is vital. The tooth has no history of having any symptoms. It's been asymptomatic. The tooth shows no evidence of periapical pathology. A tooth pulp tests vital to both cold testing and to EPT. We're going to remove all the caries on all the lateral walls, the gingival wall, the incisal wall, but we're going to leave a very small amount of caries on the axial wall adjacent to the pulp. So we're removing the carious tissue. In the central area, this caries is sticky and leathery. We're not going to poke into it to see if the pulp is there, because if we expose the pulp, then we're going to have to proceed differently. We remove all the caries over the pulp, except that's over the pulp in the axial wall. We can now proceed with our indirect pulp cap. Now, our indirect pulp cap, we're going to place calcium hydroxide Di-Cal just in the area where we expect the pulpal tissue to be in the deepest area. We then cover that over with Vitribond, covering the Di-Cal completely, so that all of the axial wall where the calcium hydroxide, the Di-Cal, is placed is covered. And this is considered a deep cavity preparation, deep cavity depth. We make sure there's no glass ionomer at any of the adjacent walls. That will be at the cavo surface margin. If we do have excess in that area, we're going to remove it with a round burr. We've placed our Di-Cal, our Vitribond, and then we do our etch adhesive composite procedure to restore this tooth with a well-sealed restoration. We're then going to follow this tooth. Every time the patient comes in for recall, we're going to make sure that the tooth's been asymptomatic. We'll do a cold test to make sure the tooth's fine. We'll make sure the tooth has no percussion sensitivity. Direct pulp is slightly different. It's when the pulp is exposed, either due to trauma or caries, and we can actually see some bleeding into the preparation itself. Just like an indirect pulp cap, it's generally going to be a deep cavity preparation. We're going to place calcium hydroxide, DiCal, cover it completely with Vitribond, and then place our definitive restorative material. Now, direct pulp caps can be broken up into, categorized into two different types of pulp capping. The first one is a mechanical exposure, an exposure that occurs not in the presence of caries. It can be due to trauma where the tooth fractures and the pulp is exposed, or it can be iatrogenic where you actually expose the pulp during tooth preparation that there's no caries in the area. The other circumstance where consideration for a direct pulp cap is a carious exposure, and in fact the clinical success of doing a pulp cap can really be differentiated by the type of exposure that the tooth has. So the question is, how successful are direct pulp caps? Well, when we take a look at a systematic review of vital pulp therapy and vital teeth with caries exposed pulps, that the success rate for vital pulp therapy for direct pulp capping, from looking at all the articles that have evaluated it that passed the highest level of evidence, that the success rate of caries exposures at 6 months to 1 year are 87.5%, 1 to 2 years 95.4%, 2 to 3 years 87.7%, at 3 years 72.9%. So that pulp capping can be successful if you follow a very definitive technique for pulp capping. The success rates comparing mechanical versus caries exposure are quite different. Mechanical exposures have a success rate of over 92%, while caries exposed pulps going out at 5 years are at around 33%. Only a third of the teeth maintain their vitality. Now that's pretty good if the patient doesn't want root canal therapy. Then the only other option would be extraction. But if you have a carious exposure, the first thing you need to present to the patient is the tooth needs endodontic treatment. It'll then need a core buildup and a crown. And if the patient says, well, I can't afford that, what else can I do? Well, the only other choice is extraction. Or we can attempt to do a pulp cap with a medicated dressing material placed over the exposed pulp. The success rate is only about 30% of the time. If the patient says, well, I'd rather not have it extracted, but I can't afford the other treatment, then we'll do the pulp cap and we'll keep on reevaluating this tooth. But you need to note in your patient record that you've explained to the patient all the different options before you've done the pulp cap. In fact, there's an Axiom code, an ADA code for direct pulp capping, and a fee for that additional procedure. Now keep in mind, the larger preparations had less success than smaller preparations. And that also comes into play that if you have a carious exposure and it's just a large exposure, a large carious lesion, that the success rate is going to be significantly less. So what are the clinical implications of this study in terms of recommendations for treatment? Well, the clinical implications of this study was that direct pulp capping was recommended after mechanical exposure with immediate placement of a definitive restoration, while endodontic treatment was the choice of treatment for pulp exposure due to caries. And this was based upon a literature review from the Journal of Endodontics in 2011. So let's take a look at the clinical considerations for direct pulp cap. And you can see from this image that this maxillary incisor for a young patient was traumatized. The tooth fractured, leaving the pulp exposed, and you can see the hemorrhage. The clinical considerations is the pulp exposure should be very minimal, usually less than 1 millimeter in diameter. The tooth must be vital, with no history of spontaneous pain, no percussion sensitivity. Any pain elicited from a cold test or an EPT shouldn't linger. The restoration you place during that visit must seal the tooth from bacteria. A periapical radiograph demonstrates no periapical pathology. The tooth must have been asymptomatic. and the tooth won't have a casting, whether it be a crown or be part of a removable partial denture. If the tooth is getting an indirect restoration of casting, then we need to do the endodontic procedure. So how do we look at success? Well, success is predicated upon the fact that traumatic exposures have better prognoses than caries exposure. Good isolation of the exposed teeth with the dental dam during all your procedure, and minimize the manipulation. Place liners quickly, and if necessary after liner placement, then remove the remaining caries. Don't remove all the caries with the pulp bleeding, where more debris can be a foreign body placed within the pulp chamber. We want to control bleeding with a damp cotton pellet. We can control bleeding with sodium hypochlorite in a cotton pellet. In fact, the clinical protocol for doing direct pulp capping would be to control hemorrhage with a cotton pellet wetted with sodium hypochlorite, the same sodium hypochlorite that you use when you're doing an endodontic procedure. Don't use an explorer tip to verify the exposure, as in this case for the mandibular canine, for the maxillary canine in this image. There's a pulp exposure. It's very subtle. I'm not going to poke in it and get it to bleed like the image in the upper right-hand corner. I can see I have a pulp exposure. It's very subtle. I clean and cleanse the cavity. I control any hemorrhage using a cotton pellet that's damp with sodium hypochlorite. I then place calcium hydroxide over the pulp exposure. I then completely cover the calcium hydroxide with Vitribond. If it's an amalgam, it would be Dical, Vitribond, barrier cavity varnish. If it's composite, it will be Dical, Vitribond, composite resin that's placed adhesively. So direct pulp capping works if you follow procedures and you also follow up to make sure that it's been successful. Let's talk about a temporary restoration, a single tooth direct restoration placed temporarily. And the reasons for doing a temporary restoration when restoring a single tooth in a single visit is that you're placing it as an intermediate step. It's part of the definitive restoration, and the reason you're placing a temporary that day is you've run out of time. It's an emergency procedure. You don't have time to do the amalgam, to do the composite, so you're going to remove the caries, you're going to smooth off the fracture, and then put a temporary in, and you want to do this start to finish in probably 10-15 minutes. You're fitting it into a scheduled appointment time in your office. Or perhaps you're having procedural problems during treatment. You start your cavity preparation, you get to the dentin, or you're almost halfway through and the patient's starting to feel it again and you can't get a numb. You're going to put a temporary restoration in that tooth because of lack of inadequate anesthesia. Or perhaps it's more convenient for you today to put in a temporary because you're booked up. Your schedule is just really a mess. Or what if the patient's a management problem? They won't sit still. They won't follow your instructions. Let's get a temporary in and we'll get you back. Perhaps the patient is very anxious and we need to use some type of sedation dentistry in order to control their anxiety. Now keep in mind, temporary restorations are not to be confused with caries control procedures, even though in Axiom in the ADA code we refer to this as a sedative filling. Okay? Caries control procedures are somewhat different. Temporary is being placed because of time limitations for an emergency. You can't get the patient numb. The patient won't sit still, won't allow you to complete the restoration. Keep in mind that might be a child who doesn't want to sit still. Caries control is somewhat different. In fact, caries control is for vital teeth. And when do you do caries control? Well, you have deep caries without pulpal invasion, as determined by radiograph symptoms and vitality testing in terms of the patient hasn't had any symptoms, the tooth tests vital, there's no percussion sensitivity, it's a large carious lesion, possible pulpal involvements. In fact, you want to see whether or not the tooth is restorable, whether Endodontic therapy can be done if the tooth's restorable. And so in order to make the decision whether the tooth is restorable, we're going to look at the radiograph, and we're going to follow that up by removing all the caries and looking at what needs to be done. Keep in mind the caries may go subgingival and there may be the need for crown lengthening. Or perhaps you want to do quadrant dentistry. It's a patient with multiple teeth with carious lesions, extensive caries, and so to stabilize active disease, you're going to do a quadrant at a time, 3, 4 teeth. You're going to remove all the caries, temporize it with either IRM, intermediate restorative material, reinforced zinc oxide eugenol, or you're going to use Fuji 9 conventional glass ionomer, and you're going to restore all those teeth in a single visit over an hour, hour and a half, removing the caries in a gross way, not defining the cavity preparation. And you're going to get everything stabilized and then go back. And this would be for patients with rampant caries. Sometimes we're going to use it as a diagnostic tool. Does the tooth need root canal therapy? Will it survive the treatment we're doing? Perhaps it might become symptomatic, and so we're going to do our caries control, put in our temporary restoration, and then bring the patient back in about 4 weeks and see if the tooth's been okay, whether the tooth's been asymptomatic, the tooth tests vital, and then go ahead and place our definitive restoration. When we're placing a definitive restoration, especially teeth with deep caries, we can leave our caries control material, our glass ionomer, or IRM, as a base in the cavity preparation, making sure all the cavo surface margins are clear, and then we can restore the tooth. Keep in mind that with IRM, composites don't have chemical compatibility. In fact, zinc oxide eugenol, the eugenol of this material, can actually inhibit the set of the composite and leave it soft where it is in contact with the IRM. And in fact, the ADA code for caries control is sedative filling. And by definition, we're removing gross caries, very soft consistency caries like oatmeal. We're removing it from the pulpal wall, the axial and lateral walls. We're going to leave leathery, carious dentin adjacent to the pulp on the pulpal and axial wall. That may still remain. In fact, it's going to look exactly like an indirect pulp cap. We're then going to go in and place calcium hydroxide, and then we're going to cover it with IRM or Fuji 9 or Fuji 2 LC. As I said, for chemical compatibility, if the tooth's going to be restored with a composite, we're going to use glass ionomer, not IRM. IRM is a zinc oxide eugenol material, powder liquid mixed on a mixing pad. So caries control with Fuji 9, and the procedure for Fuji 9 is we apply a cavity conditioner to the cavity preparation. It's a 10% polyacrylic acid. We rinse it and dry it out of the tooth. We activate the Fuji 9 capsule, mix it on a high-speed mixer, the Silamat mixer, for 10 seconds. We dispense it into the cavity preparation, fill it to full coating, to full contour. We cover it with Fuji Coat Light Cure, and this is a light cure surface coating because when conventional glass ionomers set, they lose moisture. It affects their physical properties. They become more opaque. They can actually get cracking. You can also use Optibond Solo Plus to place that over there and light cure it. Now, Optibond Solo Plus is a very expensive alternative. Fuji Coat LC is a very inexpensive alternative. You cover the glass ionomer and then light cure it for 10 seconds. Then you wait for 6 minutes from the start of the mix, and you can do your final adjustment of the restoration. Then you reapply Fuji Coat LC, light curing it for 10 seconds, and you can dismiss the patient. So let's take a look at a case. We have deep caries in this tooth. We have an existing composite resin restoration. The patient's fractured the cusp due to the caries. And you might look and you can see that the caries is going to extend subgingival on that mesial margin. The radiograph shows no evidence of pulpal exposure or periapical pathology. The tooth has been asymptomatic. The tooth has no percussion sensitivity. And the chief complaint that brought this patient in for the emergency visit was they fractured the cusp while eating. Diagnosis is steep caries combined with a fracture. We administer local anesthesia, place a dental dam while the patient's getting numb. We remove the caries with a slow-speed handpiece and a number 4 round burr. The axial wall still has leathery caries remaining. We haven't removed all the caries from that area. We place our GC cavity conditioner, our 10% polyacrylic acid, for 10 seconds. We're not etching the tooth, we're conditioning the dentin. We rinse it for 5 seconds with an air water spray, leave it dried, but it can be slightly moist. The cavity conditioner, polyacrylic acid, that enhances the bond of the glass ionomer to the dentin. And then we're going to mix the material. We're going to shake or tap or loosen the powder in the capsule. We're going to place the capsule on a hard tabletop surface and depress the plunger. We're going to place it within the applicator and click once. That allows us to activate the capsule. We then take it out of the applicator and put it on a high-speed mixer, the Silamat mixer. Mix it for 10 seconds. We then put it back on our applicator, click it twice to prime the capsule. Some of the material will come out of the tip, and then we'll apply it to the cavity preparation. So we tap or shake or loosen the capsule. We place it on a tabletop and depress the plunger. We click it once to activate, and then we mix it on a high-speed triturator for 10 seconds. We take it out of the triturator, put it into the applicator, 2 clicks to prime the capsule, and this metal button on top releases the plunger so you can remove the capsule when you're finished, and then you're going to slowly syringe it in the cavity preparation. It's going to be putty-like. It's going to flow into the cavity preparation, and then using an amalgam condenser, you can adapt it to the tooth. In this case, we didn't need to use a matrix band. In some cases, you do. The working time for Fuji 9 GP is 2 minutes. It starts to get too hard, it starts to become too rigid, and you can't apply it. So you've got 2 minutes of working time after you place it in the cavity preparation. After you've contoured it, you cover it with Fuji Coat LC, light cure it for 10 seconds. Wait 6 minutes from the initial mix for complete set. Take off your dam, adjust the occlusion, finish it, polish it with polishing paste, cover it again with Fuji Coat LC, and light cure it, and you can dismiss the patient and schedule them for an appointment for a definitive restoration. You've just viewed and listened to Pulpal Protection, Bases, Liners, Sealers, Caries Control, Module D on pulp capping and caries control.